It's now my pleasure to introduce tonight's speaker, Teresa Duncan. Teresa is a speaker and writer with over 20 years experience in healthcare. Her areas of expertise include accounts receivable, insurance methods, helping dentists and managers establish very solid management systems. Teresa is a recipient of the Educator of the Year Award by the Association of Dental Implant Auxiliaries, a component of the ICOI. Teresa certainly understands the importance of continuing education and is one of our best speakers regarding these types of topics. She's also the author of Moving Your Patients to Yes in Easy Insurance Conversations, and an annual contributing author to the ADA's CDT Companion Guide since 2017. Teresa is a frequent contributor to The Observer, The Progressive Dentist, and Dr. Bicuspid, among others, and she's served as a founding trustee for the Auxiliary Learning Focused Dale Foundation. Teresa is also a member of the National Association of Dental Plans and the National Speakers Association. Last but not least, Teresa has been named one of the top 25 women in dentistry by Dental Products Report magazine and recognized yearly as a leader in consulting by Dentistry Today. It's my pleasure to have with us Teresa Duncan. Teresa, thank you, and take it away.
Thank you so much, David. It was really cool to see everybody chiming in from where they are. I saw somebody from Atlantic Beach. It has the word beach in it, which sounds really good. So hello to Atlantic Beach and hello to everybody else. I am going to come at this from an insurance and coding point of view, and that's really what you signed up for, right? One of the biggest questions that I get when it comes to insurance has to be with the whole wide world of periodontics. So Perio always comes first, and then we have crowns. Those are always very busy questions. Then we have implants, and then it goes down to how the heck do we code in general. But we're not going to go over any of that. We're going to kind of focus just on the laser codes that are possible to use with your laser. Now, that being said, I'm just going to put some ground rules out there that when it comes to lasers, back in the day when I first started speaking, we really would not put that in the narrative to the carriers, only because there were a lot of consultants, the consultants who review your claims. A lot of those consultants actually did not believe that lasers were effective, and there's still some literature out there that they'll cling to say that it's still not, it's not proven to be, you know, the best way to treat these conditions, and I want you to appeal anytime you get any kind of determination such as that. Now, I'm going to go over the new way that your documentation is changing, and this is something that I've been really ramping up the conversation on for the last year because it has been changing so rapidly, and I'm really afraid some of us are going to get left behind. So let me go ahead and advance here. My mantra, if you've ever heard me speak in person, I say this a lot. I say your documentation is going to drive your revenue. So I want you to hold on to that the whole time that we're talking, because as we go through this, I'm going to give you some codes and I'm going to give you what to look out for. But what I also want you to think about is, this doesn't mean that I can't do it. So I want you to think about that, because in my time that I was consulting, I don't do much consulting anymore, but when I was in the office and listening, I would always hear things like, well, we can do this quad this time and we can do this quad that time. And it's really only because the benefit was there. I want you to try to separate out that train of thought, because the benefits are something totally separate than the care that you're prescribing to the patient. And I think sometimes we muddle that up. And as an experienced more than 20 years, almost 30 years treatment coordinator, I will tell you that I even slip up sometimes. So it's okay to forgive yourself if you do find yourself slipping up, or if somebody hears you slip up, just get back in the groove of it. It's okay. One time is not going to kill you. So let's go over the clinical notes and why documentation is so important. If I can't get you paid, doctor, if I can't get you paid, then we're not going to have any revenue, right? If I can't win that appeal because the documentation isn't good, we're not going to have any revenue. And then we all know what happens. COVID has taught a lot of us that cash flow is king, having cash. I know a lot of doctors that I talked to over the break, this break that we had, when they looked at their books, they realized just how cash poor they were because most of their assets were sitting in aging. And so I need us to really think about our revenue coming in and being a free flow rather than being held up by all of these blocks. The common wisdom, the conventional wisdom in the past was that the doctor would have the notes, and then when we were ready to send in a narrative, the insurance coordinator or the manager or the assistant, whomever was in charge of doing that, would take a look at the doctor's notes and then sort of paraphrase it, pull out the salient points and put that into the narrative. What I want you to do is stop doing that. First of all, there's a lot of room for error. And what I used to see was doctors would have untrained people doing this, meaning they knew a little bit, but they really didn't know the clinical terminology. And sometimes some of the narratives that I read were just not well written. And unfortunately, the insurance consultants out there have read similar narratives. So the move now, and this is in several benefit booklets out there, the move now is that written narratives are not considered to be of diagnostic quality, clinical quality. What they're looking for now is that your clinical notes are of enough quality that you should be able to just take a screenshot and send that in. So I am advising people who listen to me, listen to my classes, who I'm working with, I want you to move away from writing narratives, and I want you to work on the doctor's documentation to be so solid that all I need to do is take a screenshot and then attach the relevant radiographs, charting, etc. Now, some of us are listening to this, and I was one of them back in the day, and thinking my doctor's documentation is terrible. How I can't take a screenshot of that. That's embarrassing. I know, I had one. However, it's getting to that point that even if you're participating or not, if you want your claim to get paid, you're going to need to submit the required documentation. And that is why your documentation will drive your revenue. So that's the ground rules when we go forward with the rest of these codes. I need my intraoral images to be really clear. I really love them to be dried out. If you're going to show a tooth, I want it to be a nice dried out desiccated tooth that shows all the fractures. I want my radiographs to be labeled, the right side, the left side. You'd be surprised. I talk to a lot of insurance representatives, and I go to the meetings where the C-suites are. When I talk to them, they'll tell me, you wouldn't believe how many claims we get where the x-rays are not even labeled. So don't make that rookie mistake. That's easy to fix. In this time of COVID, what we've learned is that there's some allowances being made if you are seeing the patient in one appointment because the patient doesn't want to increase their risk and maybe they'd rather get everything done at one time. This isn't necessarily laser specific, but I just wanted to give you a tip. So if you have a patient that doesn't want to come in a lot, they just want to combine everything to one appointment, definitely make sure you put that in the notes, and that has actually earned some extra consideration and had some payments made in light of that new information, especially if they have some risk factors that are involved too, like maybe they're elderly, maybe they have some morbidity that they're concerned with. This is a lot, all right? So, and I should say too, I'm going to send you the handouts. In fact, if you want the handouts, I want you to email education@biolays.com. And David, if you don't mind just putting that email, pop it into the chat so that they know where to get it, and that way you can get a copy of these notes. I'd rather you tonight to sit back and listen and absorb it rather than trying to, you know, scribble notes down.
Will do.
I know, I've been on that side. Thank you so much. Okay, so where are you going to get all this documentation? Where are you going to put all this together? The best time to gather your documentation is always going to be at the comprehensive evaluation and at the periodontal evaluation, not the periodic, the periodontal evaluation. I always get the question, what's the difference? So the comprehensive, that's your big daddy evaluation, right? Everything is done there. The periodontal is really the same thing, but it's with the presence and signs or symptoms of periodontal disease. I would bet that a lot of you are doing periodontal evaluations, not necessarily comprehensive evaluations. That is when I want you to record all of the diagnostic information. Templates are going to help here, because if you have a template that says, that prompts you when you're missing a tooth, when was that tooth missing? When you want to replace a crown, why is the crown needing to be replaced? How old is that crown? And it's all there in the general record. Now, I understand that you only have so much time in a comprehensive evaluation, and when you're starting to use a new template, if you beef up your templates, all of a sudden it's going to take a lot of time. It gets better. It gets better. So I just wanted to give you some ideas of what to include in that. Now, I have a slide later where Dr. Lau actually has his whole repair protocol set up with templates, and you'll get a copy of that as well. But it's a lot. Templates, there's a lot to it, right? So you have to practice and get better at it. My radiographs and the charting. When you send in your radiographs, the common expectation from the carrier is that they will be less than 24 months old. If they are more than 24 months old, their hands are tied. They actually cannot approve benefits for it. That's just a rule that they have to go by. So make sure that your radiographs are current, clear, labeled, and within 24 months. I want you to record your missing teeth in the software. Make sure that it's in, if you're missing tooth number 31, I don't know if you knew this, but when the claim goes through, it actually marks on the claim form itself that tooth number 31 is missing. And as we electronically merge, the carrier software is picking up on that. So if you're looking to do an implant for 31, but your claim form indicates that 31 is still present, that may be an issue. Not all insurance carriers are doing that, but some of them have a system where it will kick back. So just be consistent with that. Radiographs, I have on there radiographs within 24 months. And then full probing is within 12 months. So, and that's pretty recommended anyway, standard of care. So full probing with lots and lots of colors in it. We'll go over that in a second. Okay, this again, not necessarily laser, but what you could do is create one for lasers. But this is my standard. I give this out in all of my courses. I'll send it to you in a full page if you'd like. But this is PowerPoint. You could probably create something on your own. And I created this so that everybody in the office would know what was required for each procedure. I wanted to do that because a lot of times my clinical team was unsure. And I know a lot of us have team members going in and out of the office. I know it's hard to find good team members nowadays. I know that we have a shortage of staffing right now in the industry. So as you train new people, the one thing you don't want to let drop is that we needed that x-ray and we didn't get it. So this is something that I would recommend putting inside every operatory on the inside of the cabinet or in the lounge. But it basically tells them what you're going to need. So my insurance coordinators out there, I'm going to call on you to have something like this in your office. Happy to send you mine. And then that way everybody's on the same page. I got really tired of hearing, well, nobody told me that you needed that. They needed it, right? So I knew that you knew that we needed it. But anyways, I digress. Okay. Let's go through the patient's periodontal path, and then let's go all the way through some of the most common laser codes. So first of all, what I want you to do, and I've lectured with Dr. Lau before, and one thing that we are in complete agreement with is that most offices don't have this to be consistent. We've talked about how some offices do this and some hygienists do this. When you have a patient coming through your office, the patient's periodontal path should be at least consistent. Not only clinically, because I'm more concerned with the billing part of it. I would like my admin team to know what is the next step, what is the workflow. So my assignment to the clinical people here is to take a look at the patient's path through the office when it comes to perio issues. And why do you go this way and not that way? Why do they go to 4346 and not straight to 4341? Those are the questions that a lot of times an insurance coordinator needs to know. If they have no clinical knowledge, it's hard for them to answer that when they're talking to a carrier or trying to get your claims paid. So help them out a little bit. What I have here is just a listing of what you could decide. I know this seems to be working really well for me. This is pretty much your standard, somebody with periodontal disease. I mean, just your standard case, right? There's not a lot of extra flapping and stuff going on here. This is the pretty standard situation. Make it match your practice. Come up with your own pathway. And I know there's a lot of offices that will do the same thing with implants. You know, what are the stages for implants? Those are super helpful to new team members coming on board because they don't know. Remember, you have a lot of institutional knowledge that they don't have. So let's make it as easy as possible for them. All right. Whew, you guys doing okay out there? All right, let's move into the codes now. So debridement, I always get this question in my perio classes. I always get this question about debridement, and it has to do with, well, can we do the evaluation on the same day as debridement? Well, no, and in fact, it became such an issue that at the last code meeting, what they ended up doing was they added, the second to last code meeting, they added the verbiage on a subsequent visit into debridement because people were doing so much billing of the evaluation and debridement. The debridement is meant to enable the evaluation. It's when there's so much fuzz and junk on there but that the dentist, the clinician cannot do a proper evaluation. So let me just take a break here to talk to you about the fact that there are going to be procedures that we need to tell our patients they are going to have to pay for, okay? They are going to have to pay for certain procedures. And I know that some of us are like, well, yeah, of course. But I want to tell you that there are very many offices out there that when it comes to telling the patient that they're going to bear a lot of the out-of-pocket, it becomes more of it's a very uncomfortable situation. So what I'd really like you to do is just get used to the fact that when you have higher level services, you guys are doing laser services, when you have higher level services, you're going to have to get comfortable with the fact that many of the procedures that you do are not going to be subject to coverage. And anyways, you only have, what, $1,500, $2,000 anyways. So we have to be really comfortable with talking about these big numbers. And I always use terms like, well, we only, your plan brings $1,500 of benefits to the table. That'll get used up really quickly. Let's talk about the rest of the amount that is due. And I just kind of get that out of the way because really, if you're talking a huge treatment plan, that $1,500 is a tiny little bit. So I don't want to focus on insurance because then they start to focus on what insurance clauses are going to tell them what's not allowed. Does that make sense? So I want you to not think so much about that. The bigger picture is the overall treatment that you're recommending. So let's move on then to 4346. This is a very confusing code to somebody who is not clinical at all. So I want to call out to you that if you want to train somebody new on this code, I want you to focus on the fact that they don't understand the word generalized in here. That seems to be the big missing link. So when you say generalized, we who've been doing this a long time, we know it's more than 30% of the mouth, right? Many people don't understand what that means because they've never come across generalized versus localized. And so that's something that you'll need to teach them about. 4346 means that there is no bone loss. There's just puffiness and inflammation and maybe some bleeding, but there's no bone loss. So taking x-rays or any x-rays that you take aren't really going to help with that. But what will help with this is intraoral images. So don't be afraid to take a lot of intraoral images right after you probe. Everything's puffy. There's some blood going on there. I hate to get all gory. I know it's late for some of you, but we're in the dental field, so it's okay. I really love when an office takes phenomenal x-rays, or I'm sorry, intraoral images that shows all of that, because that actually is a current representation of what's going on in the mouth. On the flip side, when the patient comes back in for their evaluation, follow-up appointments a year down the road when they've had some healing, pulling up those pictures, contrast it with today's pictures, you really, how much more can you show the patient that you've cleaned their mouth so much? That's going to turn them into a believer if they weren't already. So intraoral images are certainly your friends. I wish there's a lot more usage of it out there. So if you've been studying with any of the dentists who speak for BIOLAs, and you've run into this repair Perio protocol. I know there's implant protocol as well, but let's just go over this really quickly. These are the codes that go along with the Perio protocol. And Dr. Lau and I went through all of these and kind of assigned them. And so feel free to take this slide. And if you need it in a full page, I'm happy to send you that as well. And that way you can have an idea of what's available to you. Keep in mind that the CDT codes change every year, sometimes not a lot, sometimes a lot, and you'll just have to keep up on what the different codes are and what's coming up. So every year in the beginning of January, I usually give a coding update course, and you can find information about that on my website. It's free, but every year I do a coding update course so that we can all stay in the know. Now, with this, by the way, if you all are BIOLAs owners, then you already have a copy of my billing guide that was written for BIOLAs and laser owners. So make sure that you get that if you are a BIOLAs owner. If you're not sure what I'm talking about, you can get a sample of it on the BIOLAs website. And I think David or Nathan are going to stick that in the chat at some point if they haven't already. Okay, let's take a look at this. Look at this template. Just look at it. It's huge. It's huge. this is the documentation for periodontal laser usage. And this is, if you listen to any of the clinicians speak, this is exactly what they're going to tell you that they all need. If you are taking a look at all of this, you're going, holy cow, I can't put all of that in a template. You're already probably documenting it. It's just that they segmented it out for you. So really, everything is there that you normally would have. The real differences is the laser settings and perhaps the pharmaceutical changes. I'm hoping that that's there, but this is all expected to be wrapped up into your clinical notes. And so there's something that I say in my classes that I want you to keep in mind. I want your notes to be insurance friendly, but not insurance driven. And I want you to know that there's a difference there. I have run into very many insurance-driven offices, and they really are stuck on a hamster wheel because they're just looking to make sure they can get every bit of benefits out, and they kind of ignore this big picture that the patient probably has FSAs, flexible spending accounts, or health savings accounts. The patient probably has a little bit of money on their own. They know they need the work done. We kind of just scrape and chase this $1,500 or $2,000, and I want to get us out of that mindset, right? So make sure that your documentation is insurance friendly, not insurance driven. As we go through the codes, what I want you to see is the different clauses that you could run into. And if you take a look at your language in your narratives, you may be able to address them, which reduces the chance of it getting rejected by the dental consultant that's reviewing it. There's keywords with all of these. So I'll give you a trick here. Actually, let me put this because I'm sure some of you are still reading it. Let me give you a trick here. Whether or not you're participating, many times you can find online the provider processing manuals for different insurance companies. Like, for example, if you wanted to look at Delta Dental Processing Manual 2020 and you put in PDF into Google, one will probably pop up. It may be for a different state, or it may be the master one. What I want you to do with that is take a look at how they process every code. It's usually almost 200 pages long, and it goes over every code. So when I read the processor manual, and if you're participating, by the way, you should be able to access this through the portals. I'm going to look at the codes, and I'm going to say, you know what? I didn't know they would pay that if this was the case. Why don't I add that to my templates? Do you see what I mean? That's being insurance friendly, not insurance driven. Okay, so that's a very, very big difference. I just want us to comprehend that before we move on. All right, you guys are lighting up the chat in there. I see the blinking. Okay, so these are the scaling and root planing. You guys know 1 to 3 teeth is 4342, 4341 is the obvious, all the other full quads. I am not a fan of 4342, I'll tell you that. I think it messes up a lot of codes, but you know what? If it fits, you use it. And again, you code for what you do. So let's get over into the different clauses that you may run into when you're trying to get your perio and specifically your scaling and root planing covered. Osseous surgery too, right? So what we see a lot, and when you read this doesn't mean this is how you do it. This means these are the clauses you're going to run into, which means you'll need to talk to your team, or I'm sorry, your patient about what their possible out-of-pocket would be. So I'll give you an example. Let's talk about the 2 quadrants and the 7 days between visits. So 2 quadrants payable per date. Some plans will not benefit unless it's 7 days between the 2 visits if you're doing 2 quads at a time. I know, clinicians, I know, you know, there's a lot of literature out there that says, why don't we do all 4 quadrants? It's healthier. We get rid of everything. We're not reinfecting, within 24 hours, all of that stuff. And team members, if you're not sure what I'm talking about, hit me up or ask your doctor what this is about, because it's really important to recognize this. The reason we do this is 2 quads at a time. I think there's 2 reasons. One reason is that some doctors don't want to fight with the tongue. I get it. I was an assistant for a while. The second reason is that a lot of the carriers were only paying it 2 per day, and so it somehow snuck in that was the norm. So if you are not believing that 7 days should happen, make sure you put that in your notes. Talk to the patient about it. Let the patient know that this is your preferable way of treating them. This is the ideal way you would treat them. And if they decide to go forward, let them know that it's going to be an out-of-pocket expense for them. You've presented them the options. and they choose what they need to do, and then you can go home and sleep at night, right? So I know that a lot of you are really wishing, especially with the laser, that you could do more than 2 quads at a time. And you can. It's just a matter of whether or not the patient's going to be happy about the cost. And honestly, healthcare nowadays costs money. And if you're not in good health, we've got to get you in good health, and it's not going to be free. That's just the way the American market is. Okay, irrigation is typically not covered, and unfortunately, sometimes not even allowed, which means they tell you to write it off. And I fight that every time. I don't like to write off anything, not a fan, so I always fight that. Perio maintenance, this is what scares me because I see this a lot, especially with deltas, and it takes everybody by surprise, and then it sort of starts to creep into being your habit. And you got to think about whether or not you're changing your habits because of carriers. What this 4th bullet point means is that perio maintenance or an evaluation within 90 days of the last quadrant of SRP, if you go 91 days, then things will be benefited. But if you're within 90 days, they consider that to be part of the original treatment, and they'll wrap it all up in a bow, okay? So that means that you won't be able to collect for the patient if you're in network for that amount, and you just did a visit for free. That one little clause can cost a participating office a lot of money, so beware. Perio maintenances, we're seeing a lot of them up to 4 times per year, which is great. What I tell patients or tell offices is that if you get 2 paid per year, and the 3rd and the 4th when you know they're not going to cover it because you only allow 2 per year, I want you to send in a request to have the alternate benefit of a 1110 applied. That's your pro fee. I'm not telling you to rebill it as a 1110. You always bill for what you did or code for what you did. What I'm saying is to ask them in the remarks section, please apply benefits for the alternate benefit of a 1110. Sometimes the plans, they recognize it hasn't been used and they'll give you the benefit for it. Sometimes the plans don't. I still do a lot of billing. I personally am about 50-50 on this. Sometimes it works and sometimes it doesn't, but I'm really happy when it does. So give it a shot. Okay, with scaling and root planing, I'm going to save the first bullet point. We're going to talk about that towards the end. Usually you got 24 or 36-month frequency limitations. So this SRP also includes your osseous surgery. They usually share the same frequencies. You need to have your perio charting show clinical attachment loss. If it's set up to only do probing depths, then you're going to have it's going to be rejected. So it needs to be set up to clinical attachment loss, and in the software, every software has this, you can change that setting. I like lots of colors, yellow, pus separation, your bleeding points, all of that recession. I want the chart to be as complete as possible. That's going to help. Also, from a treatment coordinator point of view, down the road when we see them for another evaluation, I can point to the healing. And so I really like to have those complete charts. The current periodontal classifications, the classifications have changed, and now we're moving into staging and grading. So I'm not going to go into that because that's a whole different lecture. Believe me, it's a whole different lecture. You should probably look into it if you're not familiar with it or if you're still unclear, because as time goes on and the carriers change their policy, they're going to incorporate the latest guidelines, which is the new periodontal classifications. Perio.org has a lot of information on it. I would definitely start to incorporate this into your templates, the stage that the patient presents with, and then the grading of the current disease state that they're in. If that all sounded like Greek, that means we need to get up to speed on it. So it's going to mean that's going to probably be an office meeting topic. So slate that into your office calendar, office meeting calendar. Then we talked about radiographs. So that first bullet point, let's talk about that for a second. I always want you to give the patient a heads up that they may have an unexpected amount, or they may have a larger amount that they're responsible for if you know that that particular carrier is going to give you trouble. If you're an administrator or an insurance coordinator listening to me right now, you know exactly which plan that is in your practice. I know in the practice I still work in very part-time, the offices that I help out, I know exactly which plans always zig when I expect them to zag. And so when that comes up, I'm always warning the patient that, I'm going to try as hard as I can to get this paid. If I have to call you, that means I'm at the end of my rope and I may need you to step in and help. maybe go to HR or maybe get on the phone with me. That way, when I do call the patient's like, oh, uh-oh, and that way they're not surprised. So if that's something that you're interested in, my book is Moving Your Patients to Yes, Easy Insurance Conversations, and it's got an awful lot of conversations just like that. It's all insurance conversations. Okay, there's your, oh, look at that pretty probing chart. That's what I like to see. I just wanted to give you an example. Okay, this is an example of intraoral images and how they help. This is the exact same set of teeth. And if I'm trying to get my scaling and root planing covered, the intraoral images are going to help. If you look at the radiographs, you know, you got a little bit of something there, but this is what's going to sell it, the intraoral images. So you can see how that makes a difference. All right, let's get into the gingivectomies. So what I tried to do in these next couple slides with more of the laser-related codes, so I wanted to give you the documentation that you're going to need, and I did give you a version of the codes down there. I am licensed to distribute and discuss the codes, but I have to warn you that I am showing you truncated versions of the codes, and I have to do that because of the license. So anytime I change the code and how it looks, I have to make sure to disclose that. Okay, so gingivectomies. What they're looking for is 5 to 8 millimeters of attachment loss. That's typically what they're looking for. Let me move this out of the way here. And they're still going to be needing the radiographs and the probing. Some plans are going to reimburse when it's done on a different date. And so this is a big conversation that I have a lot because we see this, and it's usually gingivectomies that spark this conversation, grafting too. There are some plans that if you do all of this on the same day, they won't consider benefits for it. A lot of times these clauses, they don't make a lot of clinical sense to some of you, right? So that doesn't mean that you change. Again, you're going to be insurance friendly, meaning you're going to see what they cover. You're going to make sure to advise the patient of the risk, but you're not going to be insurance driven. So if you know you're running into a plan where if you're going to do those two procedures together, which means the gingivectomy, the crown and the gingivectomy together, and you know that the gingivectomy probably isn't going to be covered because of that, doesn't mean you don't do it. It just means that you give the patient a heads up because that's what you want to do. That's good customer service, right? If I go get my tire changed or if I had my house painted or something like that, if there's going to be some extra costs, I would rather know about it up front so I can at least put that into my calculations for my budget. A lot of our patients, they may look like they have a lot of money, but they're month to month or payment to payment. And we have to honor that because if you throw an extra $1,000 bill at somebody, it weighs heavy on their minds. And that's why I'm such a big proponent of trying to get it as accurate as possible. If you get it right on the nose, you should pat yourself on the back. That means you're really doing a good job. But for the most part, I'm happy to get it within 5%, right? Okay. Anatomical crown exposure. Well, and I gave you the codes down there. It's usually the 2 codes, and one's just 4 or more, and one is 2 to 3 sites. So you'll see that. And you've got the code books, I'm sure, so you can look those up. Again, they're often not reimbursed on the same day, and carriers often will see this as cosmetic. And so if you have something in there that is not cosmetic, maybe you've got a valid, I mean, I'm not a clinician, obviously. Maybe you have a valid clinical reason for doing this, of course, and that's what you're going to have in your notes. But remember, we're not going to rewrite the narrative, right? We're going to take a screenshot of your notes. So if you really believe that if you did, I shouldn't say it like that, if you firmly believe the anatomical crown exposure should be benefited, then you're going to want to make sure that in your clinical template, you have verbiage in there that shows it, and it will match, of course, on the x-rays or the intraoral images. And with crown lengthening and crown exposure, intraoral images, of course, are going to be the documentation that helps you out the most. So make sure, again, good documentation drives your revenue. Clinical crown lengthening, again, radiographs. We are definitely going to need that. I've read plenty of benefit booklets, and I always see the same thing in there. Evidence of decay or a fracture that goes below or near the alveolar crest. I see that often enough that I am now teaching to make sure that if that's what you see, you want to make sure that that's part of your template. And so do you want to put in there evidence of decay or fracture, ? And then you can fill it in if that's the case? Maybe. I think that'd be a good thing to put into your templates. I want to make it as easy as possible for you to fill all of this out. I have run into plans where they actually have, and I put it in quotes there, that they actually have a contingent that the dental consultant has to look for something that includes alveolar bone recontouring. So when you're doing your clinical crown lengthening, does that language make it into your templates? You're probably thinking it, you probably think you're documenting it, but maybe we need to use some insurance-friendly words to make sure that it floats through the procedure. Do you see what I mean? Okay. And also, it's plan specific on whether or not they pay on the same day as the restoration. I, throw a dart at the dartboard. Sometimes they do, sometimes they don't. And once I think I get it right, then I realize that it's actually employer specific, not necessarily plan specific. And that is why we're in the state that we're in, where a lot of your team members are having to call and get benefits for everybody, because there's really not a lot of standardization when it comes to these different clauses. I will tell you, clinicians, if you haven't been upfront or you're trying to figure out why it's so difficult nowadays, I've been doing this for a long time, close to 30 years now. I will tell you that the insurance coordinator position is 10, 20, 30 times harder than it was when I first started out. There's a lot to keep track of, and it keeps changing on a daily basis. Imagine if your clinical criteria changed every year. That's sort of what we're dealing with. So, all right, I'm going to get off my soapbox. Let's move on to osseous surgery. So very similar to the 4341 and 4342 requirements, and obviously you can use your laser for both of these procedures. The difference with osseous surgery, this is interesting. The code itself states that bone must be augmented or removed. And when I've done chart audits or done training, what I would see is nothing like that was even in the notes, because the dentist would assume by virtue of using this code that that was part of it. So they kind of assume by using the code that that information was transmitted. It needs to be in your notes. So would my insurance-friendly template have questions like bone augmented, any change in bone structure, yes or no, and then have a space for the designation? Probably. That's probably what I would do to make it helpful. And again, periodontal charting and radiographs, you're still on the hook for that. For osseous surgery, and even sometimes for scaling and root planing, I don't see it that often for scaling and root planing, but I have. But usually for osseous surgery, you'll see some plans will ask for a previous history of periodontal surgical treatment. And I guess it's because they expect it to be like a step process, and they're saying, this is the next level, you've done scaling and root planing, so we're okay going to this level. I mean, clinical decisions all around, right? So if you do have that, again, that's really easy. If you have a history of it in your software, insurance coordinators just pull it up on your ledger and screenshot that, or screenshot the clinical notes if it goes back that far. All they want to see is that there's proof of it. What if it's at a different office? Then you ask the patient, around what time did you have that done? Patient says, I don't know, 10 years ago, whatever. You put in the chart, patient states last treatment was about 10 years ago, isn't sure, can't remember exact date. That's what they're looking for. They're not looking for they don't expect you to come with the exact dates and documentation, but we need to give them enough information that they can actually make that decision and whether or not they're going to release benefits. Osseous surgery is expensive, as you know, and osseous surgery is hard to get paid by certain carriers. And I don't want to pick on any one of them, but again, your insurance coordinators listening, you probably know exactly which ones those are in your office. I have two that I have to fight tooth and nail to get mine done. So if you want to pop it into the chat directly to me, I'd love to hear what it is in your area, because what I do is I carry that around, right? When I talk to audiences, I'm always asking, who's the worst in your area? Who's the best in your area? And that gives me an idea of what it's like all around the country. All right, this is your laser bacterial reduction, your LBR. And I know that the clinical instructors talk about this all of the time. Hygienists that are listening, you're talking about this a lot. There is no code for LBR other than the miscellaneous code. And the joke that I always have is that anytime you have a code that ends in 999, you should just be prepared to bill it to the patient. 9999 codes, the miscellaneous codes in each category, typically are not covered. They do need documentation. They do need, of course, the narrative, and again, usually they're not covered. Unfortunately, if you are in an office that's participating, you are asked to write that off. And sometimes it's expensive, right? So sometimes you guys have some fees in there that really reflect the amount of care and work that you do during this procedure. So you have to understand ahead of time so that you can let the patient know. Now, keep in mind, I didn't say anything like, you have to know what it is so that you know whether or not to move forward with it. That's not what I'm saying at all. I want you to think about it this way. You have to know whether or not you're going to run into that so that you can prepare the patient for the extra expense. And if you're participating, you have to prepare yourself for the fact that you're going to be writing that off. So that is one of the downfalls of participation. And I'll tell you, that's a lot of why most of my private consults this year have been about, how do I get off of this plan? I'm losing money. I think COVID gave a lot of people reasons to kind of really look at their numbers, and a lot of you are realizing participation holds you back from doing a lot of these procedures. And maybe that's not the case, and that'd be great if that's not the case. So the question I get all of the time is, and this is also for materials upgrades and things like that, what if we don't bill it to the insurance company? I have the patient sign something, and then the patient's responsible for it because I have something here that says the patient agreed to it. So your typical agreements to pay extra, those are really hard to defend if the patient finds out that they wouldn't pay for it. So basically what you're saying to the patient is, please sign this form so that I can bill you for this. And a lot of times they don't understand, right? So many of you are using a HIPAA right to restrict disclosure form, and that means that the patient agrees that you don't bill for that procedure, and they're going to take care of it that day. They're going to pay for that procedure that day. They have to pay in full or else it doesn't work. So there's a lot of rules around this release form. So I want you to make sure you do your due diligence on this. What I have run into, this is the problem, is that it can be revoked at any time. And I will tell you, every time I hear that it's been revoked, it's from an office that's going, wait a second, she signed it, everything was cool, and then she talked to her insurance carrier, they told her what it was all about, and they revoked the HIPAA form, and then we had to write it off and refund the money. It's the patient's right to revoke that release at any time. So again, if you're going to do this, you need to be crystal clear to the patient what that means and whether or not it's a risk that you want to take, which again plays into, am I losing money being a participating provider? So it's individual, your mileage is going to vary. Let's talk about frenectomies and frenuloplasties. Oh, these are great words. So frenectomies, frenulectomies, you'll see the procedure codes there. I wanted you to have those there. In the notes, I want you to, if this is the case, does it interfere with proper oral care? Does it interfere with the seating of a removable prosthetic? And are there issues with speech or chewing, mastication, if this was not removed or altered? So that's from reading tons and tons of benefit booklets. Those are very common clauses that I've come across. And so would I make my insurance-friendly template have something like that in there if that was the case? Absolutely. So I would keep that in mind. Interferes with proper oral care? Probably, right? And I know that many of you are looking to medical billing to get some of this covered, and I just want to say I am not a medical billing expert, so I hope that you don't have medical billing questions for me, but I do know that there are offices that do seek to have some of these services reimbursed via their medical plans. One thing that my audiences are always surprised by is that we don't use this code called reevaluation, the D0171. And it's not just for frenectomies. I just want to throw this in there. Anytime you do a reevaluation after a procedure that you've done, this is the proper follow-up code. All of you that are doing osseous surgery and that are doing scaling and root planing, you guys get them back in about, what, 6, 8 weeks, 4 weeks, whatever your protocol is. Do you do a free evaluation at the time? I know some of you do. I wish you'd stop because I want you to get paid, right? Some of you are billing out periodic evaluation or limited evaluation. The actual code, when you bring somebody back after treatment to take a look at it, any kind of procedure is the reevaluation post-operative office visit, D171. It is a criminally underused code, so I'd love for you to start working that in. Does it take away from the benefits of the two evaluations per year? Yes, but put that on the treatment plan so that the patient is aware of the cost, so that if it's not covered, they were aware of it before. Just because the plans don't give you benefits for more than 2 evaluations doesn't mean you shouldn't do it. That shouldn't even factor into it. So don't think about that. Don't overcomplicate it. If the patient needs to have a procedure done, let them know the fees, bill them for it, do your work. Okay, let's look at biopsies and excisions. So they're often not reimbursed on the same day as the restorative procedures. I think you guys have run into that. And so I don't have much to say other than that. So they usually aren't done on the same day. And if you're going to have them come in on a separate day for the restorative, that's fine too. I think most of the time you would, of course, for the biopsy. If you're excising some tissue, you may want to let it heal and do the restorative on a different day. Again, I'm not clinical. Don't take my word for it, obviously. But there are those codes that are available to you, and I see this often used with laser procedures. So I just wanted to make you aware of that. Okay, we're coming down the pike here because my slide that includes those that usually aren't covered. I shouldn't even say denied. I should really just say up there typically not covered. Honestly, if it's denied, again, as long as you let the patient know ahead of time what the out-of-pocket costs were, it really shouldn't be something that you take personally. And I know as a former treatment coordinator, as a former manager, somebody who was talking to the patients all of the time, I always felt bad when something wasn't covered. I almost internalized it, and I was like, oh man, they're going to have a really big bill. I feel so bad. I need you to get over that because that's all about you. I need you to think about the patient, right? It's not all about you. It's about the patient. So I felt better when I knew that I was presenting this ahead of time to the patient so that it was not a surprise. So instead of striving for, I want my patient to be happy with us regarding prices, my goal was that we didn't give them any surprises. No surprises became my goal because I noticed that when patients got really, really upset at us about pricing, it was always about surprise pricing. Think about that. That's pretty common sense, right? But we need to put that into play in our offices. So imagine every one of your patients was aware of every cost that was involved, and all you're doing is saying, we're going to try to get that $1,500 from your carrier, but this is going to be your out-of-pocket expense. Gosh, that would make things a lot easier, right? Okay, so I have this up on the screen. You probably already read them, but destruction of a lesion, so that's typically not covered. Medical could work for this. Removal of the tori, medical is also something that I know a lot of you guys bill to for that. Incision and drainage, I see a lot of that being sent to medical too. And oral surgeons have been doing this for a long time. They send a lot of their stuff to medical. And in fact, I'll give you a tip, even though I'm not a medical biller, I'll say that if you have a good referral source, a good oral surgeon or periodontist, and they do a lot of medical billing, if you're an insurance coordinator wanting to learn more, I'd stop by the office or make an appointment to stop by the office. Now with COVID, we can't just stop by the office. And schedule a call and just let her know that, or him know that you're looking to learn more about it. I find that many of the specialist office love to get connections from their referring offices, and if they can help in any way, they will. And if you're working with an office that's not like that, I need you to think about that. But for the most part, when I told people in my classes to reach out to their specialist office for help with medical billing, it was pretty successful most of the time because your specialists want to help. They want to, get that relationship and solidify that relationship. Okay, so that's all I'm going to say on medical billing because I don't know much about medical billing. So we talked about that, right? So how are we doing on time here? Oh, I think we're right up there. Okay, let me just go through this real quick and then I'll take your questions. And I told David I'd stay on as long as he needed me to. I had this picture of a nice sunshiny meeting because what I'd really love for you guys to do is take this information, sit on it a little bit tonight, tomorrow or the next office meeting. I want you to share with your team what you picked up from this. I want you to share the handout. I want you to share the flow charts because keeping this all to yourself isn't going to help. And I don't want you to implement everything at one time because I gave you a ton of information. Start with the templates. Start with the templates. Your documentation is going to drive your revenue, right? I'm all about cash flow. I need you guys to get the cash flow going. Okay, so here's some resources for insurance knowledge. My book is on there. You can find that on my website or on Amazon. Dr. Blair's book has been a perennial. I mean, it is just every insurance coordinator typically has this on his or her desk. I really love the CDT companion guides that they put out, because as the years have gone by, they just keep adding different scenarios to it. It's a pretty substantial book now, so I highly recommend it. I do have a lot of free classes and webinars on my site. I do have an insurance class on my site. You can find me all over. Let me put up my information. Oh, I have 2 podcasts if you're into insurance and management and dental news and you want to hear more. I've got 2 podcasts for you. There's my information, and I hope that this has been helpful. I know David's going to come back on the line and we're going to look at some questions. You guys were lighting it up, so I'm sure there's a lot of questions. But here's how you can reach me, contact me, sign up for my newsletter so you can stay on top of some insurance news. And I know for some of you, it's almost 9 o'clock. For me, it's almost 9 o'clock. I want to thank you for taking the time to listen to this. I know I threw a lot out at you, so thank you very much.
Thank you so much, Teresa. As always, I'm neither a dental nor a medical biller, but I feel like I could take a good cut at it after I listen to you. So thank you for sharing all of your expertise. There are a good dozen or so questions. Some of them are similar, so I might be able to bundle them. Let me just sort of start at the top. I know you covered this under 4999, but I'm going to go back to it here. The question is from a hygienist named Cindy, and her question is, besides using D0180, I'll try and read it verbatim, and D0171 for evaluation and follow-up appointments, is there any way yet to get LBR or LAPT covered when hygienists do this? I think you spoke to that, but I just didn't want to assume.
Yeah, unfortunately not, Cindy. It's you know, again, you know, you guys only have a limited number of codes you can send in. I know some hygienists like to use the screening code, but I don't actually, if I look at the description of it, I don't really see that that fits. So in my mind, that follow-up or that LBR is a 999 code. Yeah, sorry.
Yeah, no worries. Thank you. I'll get to the next one here. Insurances are bundling, it's from Katie, insurances are bundling SRP with laser, making it not billable to patients. We appeal with narratives, but have not been successful. Any suggestions?
So a lot of offices, and Katie, I feel your pain, a lot of offices are utilizing that HIPAA right to restrict disclosure form where you can have the patient sign so that you can bill them. Make sure your verbal skills are really good around that, and again, know that if the patient revokes it, you've got to refund it. This is, I hate to get kind of meta on this, but this is indicative of perhaps it's not profitable for you to be in that plan. So if you're providing care and you actually are losing money on it, I don't want to even sugarcoat it. It makes no sense if you're losing money on the procedure. And I've run into, when we do some evaluations, you know, there are offices that are paying money every time they do scaling and root planing. You can't run in the red if this is the way you want to operate. So if you're running into that with one particular carrier, I would evaluate whether or not it makes sense to stay in there. So that's my meta talk. When it comes to getting it paid, if it's a hard and fast rule that it's not billable to the patient, it's very rare when I can get that overturned. So I don't have good news for you on that. I'm really sorry. Gosh, I'm saying sorry a lot. I don't like that.
No worries. These are good questions, and thank you for sharing your experience. This question is from Michelle. What if the debridement is performed by the hygienist before the patient is sent over to the doctor's chair for the comp? Patients come for their first visit expecting a cleaning and exam. Hope that made sense. I read it verbatim. Yeah.
No, it does make sense. So you're I'm assuming the new patient's coming in through the hygiene side. Before you do any of that work, there should be some indication that the doctor stopped in and said, okay, oh, I can't do this, so that there's some sort of diagnosis in the chart indicating that 4355 was warranted. So when you look at the clinical documentation around 4355, it allows for healing and the visit at a subsequent date. So most offices have some sort of guideline where it's 7 to 10 days of healing and then they can come back. So that does become problematic when the patient's coming in and they're expecting to get their free cleaning. So, and I talk about this in the book, but I'll just give you the verbiage. So as the hygienist, I would roll back in my chair and say, I really wish we could do what we were scheduled for. I would love to do nothing more than just clean your teeth and give you that preventive visit and, you know, have you on your way. But unfortunately, what I see before me means that we have to do a different procedure. And then that's when you talk about the cost, maybe even bring in the front office person or the admin person to talk about the cost. But I wouldn't fly through it and send it and then surprise them with it later. If the patient decides not to do it, that's the patient's right. And do you take a hit on production? Yeah, and I hate to say that too, but it typically is not going to be reimbursed on the same day. So it just makes sense to stop, explain to the patient what they're in for, and be very sympathetic, because nobody wants to hear that their mouth is junk. Nobody wants to hear that. But if it's the truth, we got to find a way to tell them.
Yeah, that's great advice, Teresa. Thank you. There's a few more. I think we're good on timing so far. This goes back to the new Perio information that you were sharing. The question is from Marie. Are you encouraging use of the new periodontal disease classification?
Yes, yes, absolutely. I think they've been out long enough. The AAP has had lots of classes about it. And I can't remember what Dr. Marie, who's kind of the spearheader of all of this, I believe that she said they're going to implement it for sure in 2023, I think. But what I know from talking to carriers is that they're also going to be changing their criteria to put that into play as well. When I see big, huge classifications coming down the pike, I would urge you to get ahead of it, you know, start talking to your teams about it. The classification's out there, it's solid. So if you talk to a patient about it, it's not like they're gonna, you know, go into a conspiracy theory. They're going to find information on it. And if you're billing medically for any of your services, you're going to need that. That's going to really help make your case, because the medical world operates with staging and grading of disease state.
Great. Thank you for that. There are a couple from the same questioner. I know Dr. McCollum down in Georgia, and this is a great question. She's got a couple, so I'm going to share them both with you, Teresa, and then maybe there's sort of one answer in there someplace. Dr. McCollum says, I treat special needs in Georgia. Can she charge debridement and prophy in the same visit? And then a follow-up, or at least a aligned question is, do you also need notes or diagnosis for feeding issues, i.e. lactation, and speech issues from other specialists? So special needs was kind of tying those two together.
Yeah, so, you know, and as you know, as you probably figured out, dental doesn't give a lot of benefit for those. Those would be very, very billable to the medical side. Anytime you have any kind of diagnosis of lactation, or not lactation, suckling issues, you definitely do need that documentation from the referring physician. So as far as doing a prophy on the same day, the code actually states, you know, that it's for healthy tissue. So it really, they're not meant to be coded together. So the fact that you can't do an evaluation to determine that it's a healthy state precludes them from being used together, if that makes sense. And it sounds like there's a lot of questions about that. And you know, so doctor, feel free to reach out to me too if you want to have a follow-up on that.
Okay, maybe two more. How about that? This is a question from Dr. Jun Lee or Sung Jun Lee. I'm not sure if they're a doctor, forgive me. The question is about scaling and root planing. If the patient has localized one quad of SRP and the rest needs only prophy, how do you code that? One quad of SRP and prophy, kind of separate and distinct?
Yeah.
I added that little comment at the end, sorry.
Yeah, actually, it's one of those, you send it in and let the chips fall where they may. So there really is there's no indication that they can't be used together. I mean, they're perfectly fine to use together. I think you already know what insurance is going to do. They're going to benefit for the lower procedure. So that way I prepare the patient is to let them know this is how we're going to bill it. And as you know, this area up here, we need to do a lot more work. It looks like your carrier is probably not going to cover that. So I just want to let you know about the fee ahead of time. And as the hygienist, I would use words like, you know, we're working on that area. You know, that area has been problematic, and I want to make sure we continue healing in that area. You see how I'm making it urgent, and you see how I'm really talking to them about continuity of care, not about benefits. Shift it away from benefits. Shift it to the fact that you're still trying to heal that space or maintain that space. So yeah, this is one of those where you just send it in and hope that they pay for the higher amount, but I think we both know it, they're not going to do that.
Okay, so last questions from Mark Zwick. If I'm saying your name correctly, it sounds right. Many insurance companies benefit for the procedure, therefore D4341, and not the tool used to perform the procedure, therefore Cavitron or a laser, etc. Have you come across that scenario?
Yes, and actually the code book is pretty clear on this. They don't care what modality. It's the fact that this is what you've done. You know, and I remember listening to one insurance executive. He was very funny, and he said, you know, if you get in there with a chisel and a hammer, then we don't care as long as the procedure was actually done. I know he was being, of course, you know, he was making a joke, but it's true. If you achieve it using laser, that's not precluded by the code book. If you do it with hand scaler, it's not precluded. So do you see what I mean? So it's true. It is completely agnostic of the tool that's being used. Very correct.